welcome back to the complex room. We are here talking about how to deal with failed cannulation. It's the aim of this course try to give perspective on basic endoscopy. Failed cannulation is something that we have to deal with when we, of course, start to do ESEP, and we will try to give a full overview on the possibilities that we have to deal this the failure. The session objective are identify the anatomical and technical factors contributing to the failed cannulation, recognize the clinical implication of unsuccessful first attempt, apply rescue technique such as precut sphincterotomy, double guidewire technique, or US assisted access, define the optimal timing for a second level technique, and balance success rate with patient safety in complex ESEP cases. Our poll will be: which of the following is considered a rescue technique for failed biliary cannulation? Precut sphincterotomy, precut fistulotomy, transpancreatic sphincterotomy, double guidewire technique, all the answers. It's a pleasure to introduce again Professor Rogier Voermans from Amsterdam. I will give the lead of the case.
Thank you, Enrico, for this kind introduction. I'm not a professor, but thanks for announcing me like that. Actually, I will not answer the quiz question because I took the task that I had to deal with a real failed ESEP, so not with the. So you want to try to precut sphincterotomy, the double wire, and that all failed, and then what's next? So hopefully you can answer the quiz question without my talk. And I also, so this was the title of my my talk, but I also will talk a little bit on my other hobby, so how to choose the best option for biliary drainage, and is that really ESEP? These are my disclosures. But first, if you talk about failed ESEP, then you have to know, is this a real problem? How often does this happen? And if you look at this article, it's about 9 years ago published. It's from Orlando, from a super high experts center, and they actually, when they reached the papilla, they had a 98% success rate of biliary cannulation. So if you see these numbers, then you think, why should we talk about failed ESEP anyway? But in real clinical practice, at least in the Netherlands, it's a little bit less. So we looked at our own data, and indeed in simple ESEPs you have a 90 to 95% success rate in the Netherlands. But for distal malignant strictures, this success rate of first attempt drops to about 80%, and that didn't change over time. That was the case in 2010 when we did the drop trial, and recently we repeated that for national data, and it was more or less the same. So there is definitely room for improvement or to rescue therapies if the ESEP fails. So what are the options if your ESEP fails and then the real fails? So you did all the rescue techniques as I mentioned. You can do a rendezvous, so EOS guided rendezvous. So you puncture the bile duct, coil wire down, and then cannulate alongside the